Okay, everybody, we are back. You guys get to hear my voice again for many hours. So this is kind of the beginning of Module 3. This is where we introduce tendon injuries. And so if you've listened to Module 2, where we talk about ligaments, you're going to see that a lot of the things related to ligaments are going to kind of sound pretty similar with tendons. And so let's kind of move into this stuff. It's important that we listen to this slideshow first because it kind of gives you an introduction to what to expect related to tendon injuries. And then you can move on to the specific different post-op slides related to the different tendon surgeries that we see. So basically, when we think of a tendon, I think you all know that this is the way that we think of the kind of the transition between the muscle and the bone, right? So we're looking at something that's very dense. It's a very tough tissue. It's a connective tissue. And the structure, as I just kind of said, looks a lot in some ways like a ligament. And so you'll see as we kind of go through this, that I'm not going to go into a lot of detail on the structure. As you guys remember, we haven't gone into a lot of detail just because it's not incredibly important for us clinically. But you have these collagen fibers that kind of line up. And that alignment of those fibers is really what's going to be important for what we have to think about as we're thinking about injury and then healing from an injury. So when you put the muscle and the bone next to each other, we call this a myotendinous junction. And so you have the muscle turning into a tendon and then that tendon attaching to the bone. And like I said, it looks a lot like a ligament. Water is a big piece of the tendon. And you'll notice that collagen is the other big piece. So the dry weight is primarily collagen. And then we have what's called elastin. So elastin being the thing that helps to kind of separate the cells and then bring those fibers back together. So you'll see here, this is kind of a nice picture to show that interface between bone and tendon. And you'll see again, the bone has a much more dense kind of, I don't know if I would call it a regular structure, but it has a very different looking structure than the tendon. And you can see the tendon has a little bit more of a lined up structure to it. Again, this is probably a better picture to show you those collagen fibers and how important it is to have that nice parallel grouping of those fibers and how then they attach directly into the skeletal muscle fibers there on the right side of the picture. So that longitudinal pattern is really, really important for helping to, you'll see as we talk about how the tendon, what the tendon does, it's really important that parallel pattern is as consistent as we can keep it during our healing process. So if you remember with the ligaments, there was a little bit more of what we call a weaving pattern, so a little bit more of a crisscross. And the ligament was designed that way because if you remember, it gets to a certain point of stress, and both of these types of tissue have a stress-strain curve. If you remember, we talked about the stress-strain curve with the ligament. But with the ligament, it has to get to a point where it really does stop because you're going from bone to bone. So if you don't do that, then you're going to have issues with the joint. Whereas with the tendon, we're going from muscle to bone. So you have a little bit more flexibility, as it were, to transmit force through the muscle to the bone. Essentially from the bone moving into the muscle. And so we really do have more of that longitudinal pattern that's consistent, just because, again, what we're using the tendon for is different than the ligament. Recognize that some tendons do have a sheath that goes around them, and that's providing fluid. So that's kind of that synovial fluid, essentially, is going to help provide nutrition to the tendon. And we're going to see this most frequently in places like the hands and the feet. So you have that thin tendon and then this area around it, you can see in the picture where there's some fluid, that synovial fluid that provides the nutrition, again, to keep it healthy tendon. You also have other tendons that don't have the sheath, but they have more of a thickening of the tissue. So an example of this would be the Achilles tendon. So there's actually like the fascia, you might say, around that tendon has thickened. And so it just, again, it provides, I think, more sort of stability. You know, the Achilles is a very thick tendon. You know, we have to weight bear and put a lot of power through our Achilles tendon throughout the day. And so it just provides that stability. Sometimes, I'm sure you guys have seen, oftentimes there's a bursa that's very close to where the tendon is attaching to the bone. And that bursa really provides some extra cushion in an area where there could be a lot of rubbing of the tendon directly against the bone. So there are a lot more bursas, I think, throughout the body than we expect. You saw that picture previously of the bursa at the elbow. There's a bursa basically kind of between the bone and the Achilles tendon. Probably the most recognizable bursa is in the lateral hip. So we think of, you know, all of those muscles that attach to the greater trochanter of the femur. And there's a bursa there that can get really irritable because we have so many muscles that are coming from the hip that are attaching at that area. And so that's when we get bursitis. So again, the job of the bursa is to allow for smoother movement of the tendon over the bone. Those tendons that have the sheath around them are considered avascular. So that means that there's no blood flow going to those tendons. Instead, we have that synovial fluid. So you have to think about that because as we talked about when we talked about cartilage and when we talked about ligaments, is we need that blood flow. We need to have good blood flow to tissue to allow for it to heal better. So with those sheath cutter tendons, you have the synovial fluid providing that nutrition rather than blood flow, rather than vascular perfusion, as you can see here. The other tendons, like the Achilles tendon, are going to have more blood flow to them. So the blood flow comes through that thickened tissue and provides, again, the nutrients that are needed for the tendon to stay in the best shape possible and for the tendon to heal. So there is more blood flow to those types of tendons. Tendons have very, very high tensile strength. So what that means is you can put a lot of stress and strain on that tissue before it's going to break, before it's going to tear. So during tendon stretching, the number of fibers increases. So again, you're going to start to stretch a tendon and some of the fibers are going to be included. And then as you keep going, more and more fibers are included. And that small amount of sort of waving or undulating of the fibers starts to decrease and they start to completely straighten out as you get to that end range of your stretch. So for normal load, so again, walking is a great example. Think of the Achilles tendon. We do put load on the tendon, right? During push-off at terminal stance, we're putting some load on the Achilles tendon. And so we hope we can get good elongation. It's really important that we do get elongation of that tendon to allow for good dorsiflexion and then contraction with push-off. However, as we get into higher loads, you're going to notice that those tendons stiffen. So again, this is that curve, that stress strain curve that we talked about before. And so if you think about running, with running, the Achilles tendon is probably actually a little bit shorter than it is with walking, because we need to, we're having higher loads, we're having more power from the muscle contraction. And so we don't want to increase the stress strain on the tendon by lengthening the tendon, because it's more likely to tear. So again, as we increase the load, the tendon is actually going to increase the stiffness. And we want that to allow for the load. So again, think of a sprinter who's running. We want that Achilles tendon to be very, very solid and very stiff to allow for the muscle to contract and provide that power that you need. So for injuries of the tendon, there's different ways to get injuries. One way is direct trauma. So literally like a knife. Any workers out there, your injured workers, they're working with a saw or something like that, and they lacerate their hand. So that tendon oftentimes will be completely cut through. So that's one way that we can get a tendon injury. And another way would be indirect trauma or overloading. So that overloading injury, again, going back to the Achilles tendon, think of, it usually happens in tennis. I don't know why, but tennis, or we've seen it in basketball. We've seen it with track and field, where they push too hard, they overload, and then you have a rupture. You could have what's called an avulsion fracture as well, which is where it literally pulls away from the bone, so you actually have a fracture of the bone, or you could have a rupture of the tendon. So if you're going to have that type of rupture, which is the most common, it's usually a pretty healthy tendon that just, again, the load was too strong. But you could also have what's called a mid-substance rupture. So that's usually a little bit higher up, not right at the junction of the the tendon muscle junction, but it's actually like in the middle of the tendon. And that's more likely because the tendon itself was not in good shape. So it wasn't a healthy tendon to begin with. So then it's going to rupture more in the middle of the tendon. So tensile strength of the tendon really stays pretty good. Like, we don't have any degeneration of tendons until we're over about the age of 55. So really, you hear about tendon injuries with young people, and usually it's just because the power was too much. Maybe they were pushing something too hard where they were, not doing the right movement pattern, something like that. They were compensating, and so then they end up with a tendon rupture. Over the age of 55, though, the strength of tendons do decline. So, and they say about 20% or so after the age of 55. So this is where we start to see more of that degenerative issues with tendons. And when we talk about rotator cuff injuries, rotator cuff tears are very, very common in older people. And so when you see, MRIs of shoulders over the age of 65, 70, a lot of those people have tears. And it's degeneration because the tendon is not as strong anymore. We have so many tendons. That rotator cuff is, kind of a crazy an anatomical beast. It's just, we know that there's a lot going on in the shoulder. And so, it's much more likely that the tendons are not going to work together as well as we get older. And so you're going to get degeneration and possibly tendon tears as we get older. It's pretty common. So tendon healing phases, you guys know these phases. This is going to look a lot like ligaments. The timeline, somewhat similar. There is more blood flow to tendons generally, and so it moves a little bit faster than ligaments, but you'll see that a lot of it's pretty similar. So what does our tendon healing timeline look like? Inflammatory phase, always is going to last at least 2 to 3 days. It could go up to 7 days. So if there's a significant injury to a tendon, so think of like your tendinitis. So not tendinosis, which we'll talk about the difference between those two, but a tendinitis where there's significant irritability from overuse. Recognize it could take up to 7 days to decrease that irritability, that inflammation. It's important to recognize that we should not be using anti-inflammatory medication during this time. They have found that, unfortunately, using an anti-inflammatory, which you guys don't use that much in China anyways, but if you use an anti-inflammatory like ibuprofen, that it can slow down the healing time because our body doesn't recognize the inflammatory phase, so it kind of stops the inflammatory phase. So it's recommended with a tendon injury, we're not using anti-inflammatories. It will actually speed up the inflammatory process if you don't use the medication, and allow us to heal a little bit faster and better. Repair phase takes 2 to 3 weeks, so not too bad. This is where we have the fibroblasts proliferating, and during that repair phase, they're going to make the matrix. So again, sort of the scaffolding of that tendon. At about 2 weeks, you should have basically that scaffolding or bridge between the two pieces, having had that formed at about 2 weeks. And then we start bringing in all those fibrous tissues, the scar tissue, again, to sort of lay down and just put something in the place of where the tear was or the injury. And most of the tissue that's going to come in is type 3 collagen fibers. So the problem with type 3 fibers is that they're not oriented in that nice parallel position. They're not following those nice lines the same way that the original tissue did. So again, they're doing more of that cross patterning because and they do it on purpose because we need to have something there. We need to have some sort of matrix. We need to have some sort of bridge. And so to be able to make that happen and to be able to keep some sort of strength to keep them together, we need that tissue to basically have that crosshatch pattern. And so that's initially, during those first couple weeks, the type of tissue, the type of collagen fibers that are going to lay down. And then we move into the maturation phase, which usually starts at about 40 days, okay? So during those first 2 phases, again, think about, okay, we've got these interesting other fibers that are coming into play here. And then at 40 days, we will start to try to get more type 1 collagen coming in. So we're moving from the type 3 that's a little bit all over the place to type 1 that's a little bit better. And what's interesting is during this phase, we don't get as much of the sensory system kind of overreacting. So we don't get expression of neuropeptides that are the sensory neuropeptides during this time. And so we tend to demonstrate less pain. So that's helpful to know. So we still are having healing, but not so much pain. Important to keep that in mind, that healing is still happening even if we're not having symptoms. Some of our intense athletes and people like that may assume that everything is healed and go back to too many crazy things. But remember, we are not done with the healing process yet. So again, maturation phase starts at 40 days. We have those type 1 fibers coming in. We're taking out the type 3 fibers. And so we're hoping that we can reorient the collagen into those parallel lines again. So it's during this time period at that 40 days that it's really, really, really important that we as rehab specialists are looking at the tissue and trying to do things that's going to help reorient the collagen fibers in the right direction, okay? So that's that 40-day mark This is really an important time frame for you to remember, because this is when we really are going to start trying to get that tendon to be as strong as we can, as strong and as powerful as we can. So remodeling takes 6 months, okay? So just remember that a total of 6 months is what it takes for a tendon to heal. And so we really, during, like I said, from about 40 days or even a little bit before 40 days until the 6-month period, this is when we are seeing a lot of the type 1 fibers lining up, and we need to make sure that we are doing treatment, and we'll talk about what that looks like. We're doing loading that will help provide those beautiful tendons to lay down the correct way. Okay. The frustrating thing, just like we talked about with cartilage and we talked about with ligaments, is unfortunately, even at the end of the remodeling phase, we still have some type 3 collagen fibers. They don't completely go away. And so it's kind of a mix of type 1 and type 3, which means that we don't have that beautiful longitudinal pattern, that beautiful parallel straight lines that we had with the original tissue. So it's not going to be quite as biomechanically strong as the original tissue was. So that's a frustration. We have to recognize, if it's a significant injury, that the tissue is going to be different after it's completed its healing process. So things that can really slow down a healing process or possibly even stop a healing process for a tendon: any inflammatory disease. So diabetes is a good example. Rheumatoid arthritis is another example. Any of the rheumatic problems, lupus, things like that. Those are going to slow down the healing process of a tendon. And they also can really cause the tissue to not look as pretty as we would like. So sometimes what happens is we actually get joint contractures because the tendons become very fibrotic, so very thickened. And unfortunately, with the thickened tendon, it can then lead to joint contractures, decreased range of motion at a joint, because that tendon wasn't able, again, to find that nice parallel elongation that we need in a tendon. So what are the different types of injuries that we have? It's really important that we recognize that there is a difference between a tendinitis, a tendinosis, and then we'll talk about some other options as well. But we have to recognize that a tendinitis is actually pretty rare. So when people say that they have tendinitis, remember that's only occurring when they're in the inflammatory process, okay? So that's only occurring normally 2 to 3 days, but remember we said maybe up to 7 days with an overuse injury. So most of the time, it's that patient who decided to paint the ceiling of, their apartment over the weekend, and they did a bunch of crazy stuff with their wrist, and so now they have some extensor tendinitis, okay? That will usually go away because they're not doing that activity anymore. And so, again, when the inflammation is gone, the tendinitis is gone. Most patients that we are going to see in our settings are going to be presenting with tendinosis. Tendinosis is a degeneration of the tendon. So you can see in the picture here, with tendinitis, the fibers themselves are normal looking, okay? They still have that nice elongation that we like. They are inflamed and irritable, but the tendon itself is normal. With tendinosis, you'll see that the tendon actually degenerates. So the tendon itself does not look like what we would consider a normal tendon. So in the case of a tendinosis, they lose that parallel orientation. They lose that nice straight line that we want. And unfortunately, they become less dense. So they don't have, again, that ability to transmit power as well. And what they also find is that they actually have small micro tears within the tendons, within the fibers. And so these little tears, of course, again, make it very difficult for us to use a tendon effectively, to transfer that power effectively. So this picture, I'd love to say that it's easy to see. I think it's pretty hard to see. But you can see that with the tendinosis on the right, those tissues you'll see are kind of all over the place. Whereas with a rupture, it's a relatively straight line on the left. That's a ruptured tendon. There's just this one big line where there was a rupture. So tendinosis versus normal tendon, you'll see that the fibers themselves do look different. The other possible thing that can happen to a tendon is what's called a peritendinitis, which is basically where you have that synovial sheath around tendons. Like we said, those are usually in the hands and feet. And that sheath around the tendon has that synovial fluid that helps to give nutrients to the tendon, and it gets inflamed. And so you have inflammation of that sheath around the tendon, and sometimes if it gets really bad, it can become very thick, and so it's very hard for the tendon to sort of glide through the sheath. Best example is what's called Decker-Vein's tendinotendinitis, which is a slightly different name than what's here, but basically that's what can happen with the tendons, the extensor and the abductor tendons for our thumb. And so, with overuse, with different things that we do with our thumb, that sheath can actually get very irritable. And again, it can cause thickening, so then it's very hard for us to move our thumb into extension and abduction. All right, so why do we injure tendons? One of the things that can definitely lead to it is being overweight. And then if you have that combination of being overweight and then you have bad body mechanics, then you're in trouble. We talk a lot about what's called the weekend warrior when it comes to things like an Achilles tendon tear. So this is going to be your dad or, one of your best friends who during the week doesn't really exercise, but loves to go out on the weekend and play football, play soccer maybe, and, spends that 1 hour a week doing some sort of exercise. So maybe they're a little bit overweight. They don't really have good body mechanics because they're not exercising very much. And so it's much more easy for them to put the tendon in the wrong position, try to push off, use power when they're running, and then tear the tendon. Other things that could lead to tendon tears would be a muscular type of imbalance. So again, one side is much stronger than the other. So hamstring tendon tears oftentimes happen because the hamstring is really strong and the quad's not strong enough. So then those are things that can happen. And then, of course, if we're not training correctly, so, if you are an athlete who's doing a lot of exercise and you're not getting, again, good muscle balance, those kinds of things, or good alignment with your movements, then we can tear a tendon. And then the last thing is environment. And you guys are always scared of the cold. Everyone in China is scared of the cold, which is fair. So I think you don't have to worry about this quite so much. But if you are out in a cold field and you don't warm up and you start to use too much power and too much push, or if you're a worker who works in cold environments and you're doing a lot of lifting, those kinds of things, you need to make sure you're warming up your body to make it less likely that you will tear a tendon. All right, so how do we treat? As you know, we're going to be talking about all the surgeries that can happen. sometimes we can do conservative management for tendon tears, especially if they're smaller tears. So you can certainly use modalities for treatment, electrical stimulation to keep the muscle moving, and for pain control if you want to. There is some research about using compression stockings, especially after surgery, to help with swelling and things like that. You can see, though, that with compression stuff, it says to use it 1 to 6 hours a day. I don't know how many people could do 6 hours a day. It's kind of a lot, but that's kind of the idea with compression. PRP, platelet-rich plasma. Everybody loves to talk about PRP. Everybody. And there is some research to show that PRP can work. And, one example is for a partially ruptured Achilles tendon tear. They gave them 3 injections, and they returned to play at 75 days, which is relatively quick. No complications at 18 months. So that was a good example. They also have used it with Achilles after surgery. And those people who had it after surgery did get range of motion a little bit earlier, and returned back to play earlier than groups who did not get PRP. So I think it's been a while since I've looked at the ligament stuff, but I think we talked about PRP with ligaments. Not incredibly helpful, but there is some research to show that it can be helpful. It can be helpful with certain issues with tendons. Shockwave therapy also has been found to be helpful, so that's good. So we do have that option for those of you who are into modalities. So basically what we want to make sure that we're doing is recognizing that shockwave therapy needs certain parameters and certain, pretty gold standards of how it's being done. So I don't know if you know or not how it works, but it's basically sort of perturbation. So it kind of helps to vibrate the tissue, which causes cavitation. And so these little bubbles, basically they think in the tissue is a mechanical stimulus that brings in more blood flow and helps, again, it just is helping to speed up the healing process. And so with shockwave therapy, we're just kind of trying to jumpstart and keep the healing process moving. They have found in vitro, so not in people, but in rats probably, that using shockwave does help increase that type 1 collagen. So remember, type 1 is the collagen that we like. It's what happens in the 3rd phase of healing. That's where we're getting everything to lay down the right way in that parallel line. So we like the idea of type 1. Shockwave, in theory, might help produce more of that type of collagen. It's important to recognize that the gold standard is 3 treatments at about 1-week intervals with 2,000 pulses per second. So that should be enough, which is pretty nice. I mean, I'm always about okay, let's do this in as few treatments as possible. I know people want to make money, but that's not too bad. Recognize that the best research for shockwave therapy is for Achilles tendinopathy. So Achilles tendinopathy, tendinosis, tendinopathy, Achilles tears. Remember, we can use the platelet-rich plasma, and for shockwave, we can use that for the Achilles as well. Also for lateral epicondylitis, so the elbow, shockwave has been helpful, and for calcifying tendons of the shoulder. So again, this is kind of those older people who might be getting, unfortunately, some calcium buildup in the tendons around the shoulder, so in the rotator cuff. So shockwave therapy might be helpful for that as well. Acupuncture may help. Okay, there's not level 1 evidence. There's level 2, level 3 evidence. And again, this is, a couple of years old. So maybe in the last couple of years, you guys are putting out so much research. maybe there's better research to show that acupuncture can be significant improvement. In this case, the research will tell us that it could increase growth factor. It could increase strength with a tendinosis. So again, remember that tendinosis, the tendon fibers are tearing, and they could end up calcifying or becoming thickened. And so in this case, it helps to make the tendinosis decrease. It helps to improve strength. For this one as well, the best research is for Achilles. So everybody wants to get those Achilles better. So acupuncture for Achilles tendinopathy might be helpful. There's also some research to show electroacupuncture might be better. And this research is usually with rotator cuff injuries. So if you do have a rotator cuff injury, using electroacupuncture might be worth trying. It is not recommended to use corticosteroid injections. Injections for tendon issues, especially tendinopathies or tendinosis, it's not recommended because they think it might actually break down the fibers. It only gives short-term improvements, and unfortunately, in the long term, it could cause there's a bigger likelihood of tears. And this is especially true for those patients with some sort of inflammatory disease. So if your patient has rheumatoid arthritis, rheumatic diseases, diabetes, make sure that they are not getting recommended for a steroid injection if they have a tendon irritability. Okay, so what do we need to think about generally post-operatively for these patients? If they're just getting some sort of debridement, so debridements might happen if they have that calcification of a tendon. So if they come in and there's just a lot of calcium around it, then they can just take that out. I haven't seen any debridements in China, but they probably do happen. If that's true, you're going to usually immobilize or do some sort of non-weight bearing 2 to 6 weeks. And then you're going to start really trying to regain range of motion after that point. So remember that 40-day mark, that's an important mark because that's when we really need to start loading and making sure that they have range of motion. And so we're going to increase the stress on the tendon starting at 40 days, a little before, a little after, depending on what the doctor says. And then we also need to make sure we are including eccentric exercise. Eccentric. You guys hopefully have heard this before. This is all over the research with tendon injuries and post-operatively when it's the right and appropriate time to start loading eccentrically, which usually, again, it's not right away. It's definitely more, at least I would say 2 months, maybe even closer to 3 months after a tear or a surgery, you can start eccentric exercise. And we'll talk about those time frames with each individual surgery. But you must start doing eccentric exercise. If it's just a tendinosis, we're starting those eccentric exercises immediately, right? On the first day. And I don't know if we're going to talk about this with this group of recordings or not. But remember, when you're doing eccentric exercise, there's different amounts of pain that are tolerable and okay, and different people will say different things. But you want to make sure you're doing eccentric exercise as part of your rehabilitation for any tendon injury or surgery. You're then going to progress all of your strengthening, and that will strengthening for at least 12 months. For a rupture, if it's non-operative, usually it's non-operative because the person's not moving very much. So again, we have rotator cuff tears in older people that they don't do surgery. And so if that's true, if they know it's a tear, they could immobilize them for 6 to 8 weeks. Make sure that the tendon's in a shortened position. So again, this might be for like your older person who gets an Achilles tendon rupture, and they just will put them in a boot for 6 to 8 weeks. And then we would follow it just like we would after an operation. For postoperative tendons, early weight bearing, or in the case of like a rotator cuff, significant resistant type activities early could lead to a re-rupture. So we're usually starting with passive range of motion, and we need to do gentle, controlled, passive range of motion to allow for lengthening of that healing tendon, to again allow for decreased adhesions and really good laying down of the fibers the way that we want them. So immobilization initially and passive range of motion is okay, but we do not want to immobilize for long periods of time. We do not want to immobilize for long periods of time. Really important, and you'll hear that with every single one of these recordings, every single one, right? So they put these animals, oftentimes they'll put the rat or the pig or something on a treadmill or something else, and they will, or in this case, they will immobilize them. So they'll tear a tendon, they'll fix the tendon, they'll put them in a cute little brace or a cast or something. And what happens is they'll immobilize them for 4 to 8 weeks, according to this. And what happens is when they take them out after that immobilization, they're much more likely to have load failure. So they're much more likely when they start to weight bear again and put, let's say the Achilles tendon, they put more load through that tendon, they're much more likely to have another tear. And they're also going to be significantly stiff. So here's some examples. I always love these. So they have some pigs, and they divided them into different groups. One was just like let them just do what they want. Another one, they did 8 months of training on a dirt track. And 4 months of getting on a treadmill 5 times per week. And those who did the exercise after, again, they injured a tendon, they fixed a tendon, they had them do exercise. Those who did the exercise had better collagen, higher collagen content, higher stiffness, which is good in the way that we're talking about. And they were able to do things basically better than the group who didn't do anything. Another study on rats actually found that in this case, strength training did not improve anything, but endurance training, so using small loads and small pressure, did actually change the tendon properties, so did improve the collagen content and those type 1 collagen fibers. All right, so I mentioned eccentric training, eccentric exercise. Eccentric, what they found is by using eccentric exercise, you actually, again, you smooth out the fibers. So you have these mini contractions that help to line up the fibers better. It also is possible that there could be decreased kind of stimulation of pain mediators, especially with something like tendinopathy, which obviously if there's decreased stimulation of pain mediators, that means that there's decreased pain. So you don't feel as much pain after doing eccentric exercise. So that's always a good thing. And again, we'll talk about with individual things kind of how much pain is okay. I would say if you can keep your patients between 2 or 3 out of 10 pain while they're doing their eccentric exercise, for let's say a patient with tendinopathy, you're doing fine, and that's okay. As long as it's not increased pain or increased pain afterwards. So soreness afterwards, we know that's normal, but pain afterwards is not. So just keep that in mind. That's kind of a good rule. All right, so let's summarize. When we talk about tendon healing, what are we talking about? So, unfortunately, unlike bone, which is module 4, When we heal a tendon, we are not healing the tendon with the same tissue. So there is type 1 collagen that comes in, but type 3 collagen is also part of the healing process, and it doesn't go away completely. So that means that the repaired tendon, the strength could be reduced up to 30%. Our goal, of course, is that that number is much less, that the strength might be reduced slightly, but that it's very, very minimal for most of our patients, that they wouldn't even notice it. But keep in mind that that is true, that this tissue is not the same. Loading a tendon, loading the tissue, just like with any tissue, helps to increase the growth factors, which will help to bring in the correct collagen and organize the correct collagen, as well as decrease the possibility of adhesions. So it keeps the range of motion. You don't want to overstretch, okay? We'll talk about that with Achilles tendon repairs. You don't want to overdo, but you do want to load it so that we have tissue that is in the right position. We don't have too much of that cross-hatching, too much of that, which can lead to adhesions, thickening of the tissue. So that means early, passive, and active assistive range of motion after surgery is very important. You have to, of course, talk to your surgeons about which one is the most appropriate. Should they be doing passive? Do they want them doing any type of active assistive initially? And as we go into different types of surgeries, we'll talk about if active assistive is okay or if it should stay passive. But, again, this is all about what the surgeons say. But make sure the surgeons recognize you have to be able to start doing passive range of motion immediately or pretty close to immediately after surgery. And active assistive can be helpful as well. Be careful not to maximally strain, so don't go all the way to end range when the tissue is healing. But you also do not want to immobilize, because we know that immobilization is bad. Okay? So you have to make sure you are checking in with your patient as you're working with them and doing this passive or active assistive range of motion, and that you're trying to do as much as you can without going to end range without straining. There is no specific definition of what that looks like yet. So I can't show you research that says this is exactly what you're supposed to do at exactly this time. This is where we should be doing more clinical research to help us understand that. But I think we can have some pretty good time frames depending on the tissue, and we'll go through each of those as we go through each of the types of injuries and surgeries. Okay, so that's it for now.